Online?
Yes, ma'am. Now we're on live. Now I have to share this on our project group.
Is my voice clearly audible?
Yes, ma'am. You are clearly audible.
Okay.
We are live in a page and we will share it on a group. The group is private, and in the group, most of us are kidney patient.
Sure.
Just give me a second.
It's clearly
We can start.
Yeah. Good evening. Shall I start? Yes.
Yeah. শুভ সন্ধ্যা, আসসালামু আলাইকুম সবাইকে। আশা করি সবাই ভালো আছেন, সুস্থ আছেন। প্রতিবারের মতো আমাদের আজকে লাইভে উপস্থিত আছেন একজন বিশেষ অতিথি। আজকে আমাদের সঙ্গে আছেন ডক্টর ক্রিস্টিন জর্জ ম্যাম, and she is a consultant nephrologist and renal transplant physician at Aster Hospital, Bangalore. And her qualification is MBBS gold medalist and MD in international medicine and DM in internal medicine and DM in nephrology. And আজকে আমাদের আলোচ্য বিষয় হচ্ছে পোস্ট ট্রান্সপ্লান্ট আউটকাম আফটার ট্রান্সপ্লান্ট, অর্থাৎ ট্রান্সপ্লান্টের পরে কিভাবে দীর্ঘ সময় সুস্থ থাকা যায়। এটাই আমাদের আলোচনার বিষয়। আমরা মূলত এই রিলেটেড প্রশ্ন বেশি নিব আমাদের অডিয়েন্স থেকে। And ma'am, this is our group. We have about more than 1,000 patients here. Most of them are kidney transplant recipient. Some of them are CKD and some are taking dialysis. And most importantly, many of us are preparing for a transplant. And this is a totally non-profitable organization. We have some doctors, some urologists, some vascular surgeons, and some specialized nutritionists here. And first of all, I would like to thank ma'am for being here, and I will thank on behalf of our patient, on behalf of our group. Welcome ma'am to our group.
Thank you, Rafi. Good evening, namaskar, assalamu alaikum, sabiko. Thank you, Rafi, first of all, for having me here and making me a part of this wonderful group. It's always great to interact with
part of this wonderful group.
Is my voice echoing?
No, ma'am.
Okay.
It's clear now.
Yeah. So thank you, Rafi. So it's wonderful to be part of a patient advocacy group, a group wherein patients are directly participating in their, treatment and health awareness. It's I'm sure that Bangladesh and India we share a lot of common things. It's hot summer here in India and the heat of summer and the heat of the ongoing elections in our country. So I think Bangladesh is also having hot summer at this point of time. So today we are going to discuss a very important topic, that is about long-term outcomes of kidney transplant. Yes. So what I'll try to do is I'll try to briefly touch upon the topic and what are the issues or what are the problems in long term after kidney transplant. Okay. What can you do as a transplant recipient for better outcomes in the long run, and then we can take questions from the audience. All right?
Okay, ma'am.
Yes. So we all know that kidney transplantation is the best form of treatment for kidney failure worldwide. Out of all the treatment options we have, kidney transplantation is undoubtedly the best form of treatment, and it provides not just better quality of life as compared to dialysis, wherein you have to get hooked onto a machine every other day and with lot of dietary restrictions, travel restrictions, and lot of symptom burden while on dialysis. Transplantation provides much better quality of life, and not just that, it provides longevity. And it's been proven beyond doubt that you live longer after transplant as compared to continuing on dialysis. So now, how long does the kidney last after transplant? It is a very valid question.
Yeah.
And this is where comes the long-term outcomes, which we are going to discuss today.
Yes.
So in the last 2 decades or so, in the kidney transplantation field, the immediate graft survival has become excellent, I would say. So the 1-year graft survival is more than 95%, which is, we have achieved the maximal, maximal target, I would say, in terms of short-term outcomes. It is very good. Most of our patients are doing very well at 1 year, 2 year, 3 year. But when it comes to long-term, that is beyond 10 years, 15 years, there are issues which creep in. So when we talk about the median survival of a transplanted kidney, how much is it? As per the data from the Western countries, the large registry data of transplant what we have, now the median survival of a live donor kidney transplant is around 17 to 19 years. And that from a deceased donor or a cadaveric transplant is about 11 to 12 years. This is a median survival. That is, it is an average. There are people who may have a very well functioning kidney for more than 20, 25 years, or there may be people unfortunately having a issue before this. And these numbers are in a ideal scenario wherein there is continued monitoring and surveillance. And in country like ours, be it India or Bangladesh, we know we have practical issues, and the median survival may not be, these numbers may not be seen in large number of our patients, unfortunately. So what are the issues or what are the causes which lead to early graft failure? So looking at that, we can divide or we can broadly classify the reasons for graft failure as immunological reasons, immune mediated reasons, non-immune mediated reasons, and thirdly, it can be that the graft or the transplanted kidney is functioning well, but unfortunately the patient dies because of some other reason. So these are 3 broad classifications of the issues coming in the long term in the kidney transplant. Okay, so now let's begin with the immunological causes. Okay, first I'll try to explain in brief what are the causes, and then we will describe in brief what can you do as a transplant patient or a patient who is preparing for transplant to optimize or to make the kidney last longer. Okay, so firstly, the immunological reasons. Okay, immunological reasons mean we all know our immune system in the body is a very robust, it's like an army waiting to fight anything that the body sees as a foreign substance. It will fight. Okay, so and this system we are trying to modify with our medicines when we put a transplant kidney or a graft kidney from anybody. It could be your mother, father, brother, sister, or it could be your wife, uncle, aunt, anybody, or a cadaver victim with whom you have no, you are not at all related. Also, such a kidney functions well in the body because of the medicines we give to modulate or modify this immunity. So, immune mediated causes in the long run can happen because of various reasons. Despite the medicines which we give at the time of transplant and the various tests which we do to find out the compatibility, we do tests like HLA testing, cross matching, and sometimes we do DSA testing at the time of transplant to see what is the compatibility between the donor and the recipient. Despite all this, there can be issues like rejection. We have seen acute rejection, acute cellular rejection, antibody mediated rejections can happen, or chronic rejection can happen in the long run. So some of the factors which can increase the risk of rejection, for example, if there is lot of mismatch, HLA mismatch between the donor and recipient is one reason. Or prior sensitization, if somebody has received multiple times blood transfusions while on dialysis, waiting for transplant, it can produce antibodies in the body, which can increase the risk of rejection after transplant. Similarly, other sensitization event like pregnancy is a sensitizing event. So pregnancy is a state wherein a child is in the mother's womb and child's HLA is different. So the body can form some kind of antibody which is naturally happening during pregnancy in anybody. So such women with multiple pregnancies in the past can have antibodies naturally. Or prior transplant. Anybody having a failed transplant coming in for second, third transplant also has higher chances of having antibody and a higher chances of having rejection, and hence the long-term outcome may be compromised because of these factors. So these are some of the immune-mediated causes for poor long-term outcome, I would say. Okay. Now, the other second part is non-immune mediated. That is not immunologically mediated, but again affecting the transplant kidney. So these can be problems like infection. There can be infections in the transplanted kidney, like BK virus infection, or sometimes graft pyelonephritis. These infections can affect the kidney, and even if treated, then again, whenever any infection happens, or for that matter, a rejection episode, it is not that the kidney is immediately damaged. Most of these situations we are able to treat, but after treatment, some damage persists. And in the long run, the kidney, which otherwise would have, let's say, gone for 10-15 years, the life of the transplanted kidney is cut short because of these episodes of rejection or infections. Then other causes like some of the medicines itself which we give, like tacrolimus, very high levels of tacrolimus can sometimes cause acute kidney injury and acute tubular necrosis in the transplanted kidney. Then there can be like obstruction in the kidney. There can be obstruction in the ureter, or in the transplant renal artery there can be obstruction or stenosis, which can lead to compromised function in the long run. Then there can be problems like if the donor has been an elderly donor. So with age, normally the kidney reserve falls. So if the donor has been an elderly donor, the long-term life of the transplant kidney may be shorter as compared to a donor who is younger. Then there can be issues like recurrence of disease. So originally the kidneys would have got damaged because of some disease. In some situations, we are able to find out why the kidneys were damaged by a biopsy prior to transplant. But in many patients, we are not able to pick up the disease because already the kidneys are shrunken and patient is started on dialysis, and we are not able to know why the kidney failed. So there are many diseases which can come back in the transplanted kidney. So there are diseases like IgA nephropathy, FSGS, and many more, which can come back slowly after transplant, which can affect the long-term transplant outcome. Then another is diseases like diabetes, which the patient could be having diabetes prior to transplant, which continues and can cause damage in the transplant kidney. Sometimes diabetes can come newly after transplant, which can again have adverse effects. Poor controlled blood pressure or high cholesterol can also have ill effects on the transplanted kidney. Smoking is a risk factor which can affect the transplant kidney. So these are some of the non-immune mediated causes for poor long-term outcome. And thirdly, what I was discussing is that the graft is functioning well, but the patient unfortunately dies of some other cause. So again, this is a important problem because there is cardiovascular disease. Patient so let's say somebody who was on dialysis for a long term, diabetic, hypertensive, has underlying heart disease. After transplant, this heart condition may not have been addressed, and they can suffer from cardiovascular diseases, heart attacks, stroke, brain stroke. They can get infections. So like I told, the immunosuppressive medicines which we are giving, which is to control the immunity so that the transplanted kidney is not rejected, there is a side effect of the same, that is body's immunity is lowered. So because of that, infections sometimes can be very severe infections and it can be life threatening. And thirdly, as patients of transplant are living longer, 10 years, 15 years, sometimes we see that they develop cancers. Malignancy is another reason of loss of life in the long run. So these are some of the causes. I have not covered everything, but some of the causes of graft loss and loss of life in the long run that we see. And these are the issues which we should address to ensure that the long-term outcome is good. Okay. Now I'll briefly touch upon what are the things we can do to address these issues. Okay. So beginning with the immunological causes, I said immunological causes of poor long-term outcome. What can you do as a dialysis patient? What you can do is if a transplant is planned, and I would say that everybody on dialysis should be aware that the transplant is an option and should be the option to everyone. Reduce or avoid blood transfusions. Blood transfusions will cause sensitization and antibody formation. So as far as possible, do not transfuse or do not get transfused with blood. Take your blood injections, erythropoietin, iron injections regularly so that your hemoglobin is maintained. So that whenever you get transplanted, your long-term outcome is good. So we should not just focus on the 1 year, 2 year period. You should focus on the 10, 20 year. Because when we talk about the average lifespan of the kidney as 15 or 20 years, a young patient, 20-year-old who's getting transplanted will require another transplant 20 years down the line when he's 40, 50. So you should have a long-term plan and avoid transfusions as far as possible. Once you are transplanted, you should take your medicines very, very strictly. Very religiously, you should take your medicines. Non-compliance is a very important issue when we talk about immune-mediated rejections. And it is not seen immediately. You may have missed a dose. You would check your reports. You will do your blood test after 1 week, 2 weeks. Oh, my creatinine is normal. I missed my dose, but my creatinine is still normal. Then you tend to become careless. You may miss another time. You may miss a third time. It will affect in the long run. Long run, slowly these antibodies can start forming and something known as chronic rejection. And chronic rejection, now the studies have shown that one of the important reasons is under immunosuppression. That means either because of non-compliance from the patient side, missing doses of tablet intermittently, or for some reason had an infection, we had to reduce your immunosuppression, we could not restart. Underdosing, for some reason the immunosuppression dosage is less, can lead to poor outcome in the long term. This is very important to understand. It may not appear immediately. You would be doing your test every month, every 2 months. You will be happy your creatinine is 1, 1.1, 1.2. But it can start showing slowly over 6 months, 1 year, when your creatinine can start slowly increasing. You understand what I'm trying to tell? It may not appear immediately, but in the long term, for long-term graft outcome, low immunosuppression leading to antibody formation and a chronic rejection becomes an important cause. So there comes the importance of compliance and taking your medicines regularly. And very important is regular follow-up, because any such increase in creatinine, any proteinuria can be detected early, so that we can address those issues early on. That is important. Along with that, getting your TAC levels done periodically so that the medicine's dosage is maintained becomes important. You should get your diabetes. If you have diabetes, sugars should be under control. Blood pressure control is very important. Again, poor blood pressure control can affect your transplanted kidney in the long term. It will affect your transplant kidney's life. So get your blood pressure strictly under control. That is important. Sugars under control. Your cholesterol under control. Follow a diet which is healthy. Exercise. Have a healthy weight. All these becomes very important when you plan, when you look at the long-term outcome. If you have habits like smoking, please stop smoking. So these are important. And also get periodically checked for proteinuria. For example, if a disease recurrence, when we talk about disease recurrence, you may have had kidney failure because of some disease like IgA nephropathy, FSGS, which can come back in the transplant kidney. How will you know it has come back? You will know only by testing the urine and blood. So that is why periodic checkups become important. Even if you're feeling all normal, everything is fine, please get periodic checkups done so that we can detect a recurrence early. If a disease is coming back, if we detect early, we can treat. That is important. And then another thing is, I spoke about heart disease and malignancy, cancer as a cause of mortality in transplant patients. So again, getting your heart checked, getting yourself screened for cancers, age appropriate screening. For example, females should get a mammogram or a pap smear periodically. Transplant patients are at increased risk of malignancy compared to normal population, which is again important to understand. When you live for 20-30 years after transplant, you should also look for or screen for cancer, also have your heart checked periodically. This becomes important. And another important thing is infection. And infection prevention is very important, especially in countries like ours, India or Bangladesh. We have a lot of overcrowding. Within the house and within the community, we live in close proximity. A lot of us are living together. So, and infectious diseases being a tropical climate, infections can spread very fast. So a healthy person having an infection can give the infection to a transplant recipient. And even after 5, 6, 10 years after transplant, we have seen patients coming with very bad infection. So how to prevent infection? It should start from the stage when you are planning transplant. You should have your vaccinations completed. Now we have vaccines to prevent a lot of infections, not just hepatitis B. We have pneumococcal infections which can be prevented, influenza. Now we have chickenpox. Chickenpox and the zoster can become very severe after transplant. So vaccinations prior to transplant is important. Wearing mask and having your general precautions to prevent infection, especially when you're going to public places, these should be followed throughout. This become very important to prevent infection. So these are some of the aspects which you should follow as transplant recipient to ensure good long-term outcome of the transplant kidney. So anything with respect to this questions, now we can take one by one, and I will.
Before taking question, I would like to ask one question regarding the issue you are talking about. Like we are talking, average outcome of transplant might be 70 to 90 years. It was you're talking about. Most probably in Bangladesh or India, we are not doing epitope matching of DR or DQ.
Sorry, Rafi, your voice is little breaking in between.
Ma'am, am I audible or not? Can you hear me?
Yes, I can hear you. Yes, tell me.
My question was, you are talking about the average outcome was 70 to 90 years.
Yes.
As far as I know, in Bangladesh or India, we are not doing epitope matching or DR or DQ.
Yes.
If we do that, it will it increase the average sustained rate?
Correct. Good question. So now high resolution HLA typing is being done in many centers. So this is what is epitope matching and the high resolution HLA typing, wherein we look at high resolution matching between the HLA of donor and recipient. And yes, this can provide better matching, and also we can look at the antibody profile in a better manner when we have high resolution HLA typing. So now there is evidence that when we look at long-term outcomes, especially in the Western countries, there is a periodic checking of antibodies which is done, which again in India and in Bangladesh, we don't do a periodic or a regular antibody monitoring after transplant. So when we have a high resolution HLA to begin with, we try to match it at the time of transplant. And if there are antibodies, we can choose the best donor for the given recipient, depending on the epitope typing or the high resolution typing. Then after transplant also, we can monitor the recipient in terms of antibodies, whether the patient is developing any antibodies against the donor kidney. So yes, these have a role, and immunology, transplant immunology is, as we speak, there are a lot of advances happening in transplant immunology. We are trying to make it more personalized medicine, what we call. So we are trying to tailor make our immunosuppression depending on your immunological risk, depending on the HLA matching, and depending on the level of antibody. So this is an evolving field. Yes. Sorry, I think you're muted, Rafi.
Yeah, ma'am. Can you hear me now?
Yes.
Another question from mine. You are talking about proteinuria. We are just seeing that after 1 or 2 year or 3 year, patients are having proteinuria. And not only this, after 7 or 8 years, most of us having proteinuria, high creatinine. And proteinuria is a very dangerous fact recently. We have seen it. And how can we get rid of this scenario?
Yes. So it is very important to understand that proteinuria needs to be evaluated. Okay. So the first thing is, immediate after transplant, sometimes protein leak can be there. One is from the native kidneys. If you are having urine output prior to transplant, sometimes from the native kidney, some protein leak can be happening. But usually it never crosses 1 gram. So after the initial 3 to 6 months, if proteinuria is there which is more than a gram, it is abnormal, and we try to investigate, and many times we do a biopsy in the transplant kidney to understand what is the cause for proteinuria. And this becomes very important because there can be multiple causes. For example, uh, rejection can have proteinuria. The recurrence of disease can present with proteinuria. In the long term, chronic graft dysfunction can have proteinuria, and the management of proteinuria varies depending on what the cause is. So, and proteinuria is not just depending on the protein intake of your diet. Okay, so there are specific reasons. Even if your protein intake is high, protein should not come out in the urine. So if the protein is coming out in the urine, which is more than a gram, and it is consistently there, and you have ruled out infections, there is no urinary infection, and other things have been ruled out, we usually do a transplant kidney biopsy to understand what is the problem, and accordingly we give treatment. So controlling proteinuria is important to for good long term outcome.
So, is it totally reversible?
Correct. So that's a good question. It depends on various factors. One is the stage of detection. Okay. For example, somebody who's on regular follow up, we know when proteinuria has started. We usually do every 3 months. If we know the native disease, it is a proteinuric disease to begin with, which can come back in the kidney. We closely monitor every 3 months. We do urine test. Or if everything is normal, at least 6 monthly to 1 year urine test should be done after transplant. And if we see that protein leak is happening, we monitor it more closely. If it is increasing, we do a biopsy. If it comes, let us say, a disease like IgA nephropathy, which has come back in the transplant kidney, we have medicines to reduce the proteinuria. We adjust the immunosuppression drugs like MMF. We try to increase the dose. Sometimes steroids we slightly increase. We add certain medicines to reduce the proteinuria, and proteinuria can be brought under control. If biopsy shows, let us say, something like a rejection which is going on, we try to treat that rejection, and that can control the proteinuria. Likewise, sometimes it can be infection which is going on, which is causing protein leak. Then we try to control the infection. In fact, we may have to reduce the immunosuppression. So yes, it is definitely manageable, and in some situations we can very well control the protein to near normal range. So early diagnosis becomes important.
And now I'll take question from the audience. And first question is from one of us. Ma'am, let me see this. And the question is, what is the clinical side effect of high or low dose of MPA level?
High or low dose of?
MPA level, mycophenolate level.
Mycophenolate, okay, MPA. So, so unlike tacrolimus, wherein we do the levels and we try to adjust the dose, mycophenolate levels are not routinely done. There are some centers which are doing MPA levels, but routinely it is not done. Usually it is a weight-based dose which we give. Again, in some patients, in the standard doses itself, we find that they get frequent infections or they get low counts. The WBC count falls, the platelet falls. So mycophenolate has an effect on the bone marrow. It can reduce the counts, the cell counts can come down. It does increase the risk of infections. These are the common side effects which we see. So if somebody is having consistently low counts, we try to reduce the mycophenolate dose. Or if somebody is getting infections frequently or had a severe infection in the recent past, we try to keep the mycophenolate dose low. So it is more like a clinical decision because it is the overall immunosuppression of the patient which is important. Tacrolimus, definitely we do levels and we try to target level. Mycophenolate, we look at the clinical parameters to decide on the dosage. So there is a standard dose, weight-based, that most of the centers are following, and we sometimes come below the dose if the clinical situation demands. Okay, this is about the side effects are seen usually when the dosage is higher or the overall immunity is higher. If it is underdosed, what are the problems? So if it is underdosed, then comes the problem of rejection. Rejection may not happen as an acute rejection. It can be a smoldering kind of ongoing rejection. Patient can develop antibody, chronic ABMR, antibody mediated rejections, and poor long-term outcome can be a issue with underdosing of MMF.
Okay, ma'am. The next question is also related to MMF. The question is it related to WBC level?
Yes. So MMF can cause bone marrow suppression. It is one of the side effects of mycophenolate mofetil. And so each patient's metabolism is different. Any drug which we give, each patient's metabolism is different, and it can cause low WBC counts in some of the patients. It can even cause GI intolerance is another side effect. They can have loose stools or dyspepsia with that. So we try to adjust the dose so that these side effects are manageable. Yes, bone marrow suppression is a side effect of mycophenolate. Low WBC counts can happen because of that. Yes.
Ma'am, another question is, how can we understand that prednisolone dose is sufficient? And if nephrologist increase prednisolone, what is the rules to reduce it?
Yes, so prednisolone, usually at the time of transplant, we give high dose steroids. Usually in the form of injectables we give for the initial 2 or 3 days. Then we give oral steroids. Initially it is high dose oral steroids which we give, which is tapered over usually 1 to 2 months to a minimum dose of maintenance. Usually is 5 to 7.5 milligram of isolone is what is the maintenance dose, which is usually continued lifelong. There are some centers which follow a steroid withdrawal protocol wherein steroids are completely taken off after a initial couple of months. But majority of centers are continuing, at least in India, and I'm sure in Bangladesh also, is patients are continued on a low dose steroid lifelong. Now, there can be situations wherein we have to increase the steroids. One such situation is an acute rejection episode. So, if there is a acute rejection which is suspected or proven, we start the patient on high dose steroids. Again, usually we give initial 3 days of injectable steroids, and then the patient is again put on high dose oral steroids, which is lowered over a period of few days to weeks. This is one common situation wherein we increase steroids. Then there can be situations of some diseases, glomerular disease or immune mediated disease, which come back in the transplant kidney, or it can come as a new disease in the transplant kidney, which needs more immunosuppression, we increase the steroids. These are some of the situations, and sometimes if, for example, MMF, we are not able to give full dose for some reason, the WBC count is low, so then we may try to keep the other two, tacrolimus and Visolone, at a higher dose. That is tacrolimus and steroid, we try to keep a higher dose. If the MMF, for example, for some reason we are not able to give full dose, or we have to excuse me, reduce the dose. So these are some of the situations wherein we have to increase the steroids. But having said that, high dose steroids in the long run has side effects, so we don't give it for more time. We try to bring it down as fast as possible.
Ma'am, another question from mine. Which is better from your end, mycophenolate or azathioprine?
Mycophenolate
or azathioprine?
Azathioprine, yeah.
Okay.
Okay, so it's a very good question. So see, as the transplant, if you see the timeline, how the medicines have developed and how the transplant outcomes. Initially, it was cyclosporin and azathioprine along with steroid, which was used for a long time. Then came tacrolimus, MMF, and steroid, which is now become the standard triple drug immunosuppression, which we tell. In terms of the potency, or how strong a medicine is to prevent rejection, or prevent rejection, MMF is superior. Tacrolimus MMF is superior than the azathioprine cyclosporin. But again, here there are certain important factors which we have to consider. One is affordability. There is a huge cost difference when we talk about MMF and azathioprine. So there are patients for whom continuing MMF lifelong becomes a challenge because of the cost issue. So there is high risk of them missing their dose of MMF. So missing dose of MMF poses a lot of risk for rejection. So such patients we counsel and we put them on azathioprine. So azathioprine, they do well on a tacrolimus azathioprine Visolone combination also. So it is very important to discuss these issues with your nephrologist, and not just financial constraints. There are patients who don't tolerate MMF. Some patients have a lot of GI intolerance. They develop loose stools, a lot of bloating. Usually these symptoms settle during the initial couple of weeks, months after starting. But there are few patients who don't settle. And if the symptoms are severe, they're not tolerating, we have to switch to azathioprine. And there are patients who do well. A lot of them do well on tacrolimus, azathioprine, and Visolone. Then there is the situation of pregnancy, where an MMF we cannot give. So when a pregnancy is planned, and pregnancy after transplant should always be a planned pregnancy, I say. And during that phase of planning itself, we have to change the MMF to azathioprine. So these are some of the situations wherein we change MMF to azathioprine. But as a routine, tacrolimus MMF combination is superior to a azathioprine based combination in terms of potency, immunosuppressive potency. Okay.
One question about medicine related issue for one different individual. How much methylprednisolone is correct dose? Is it 500 milligram 3 doses or more? My nephro suggested to me 1 gram for 3 days, or another 1 gram for 5 days. Which is preferable?
Right. So in such situations, there is a lot of, how do I put it? It should be tailor-made to the patient, and every patient is different. Every patient's transplant scenario is different. So it is not possible for any nephrologist for that matter to tell that this is right and this is wrong. So and unfortunately, with respect to these aspects, steroid dosage, especially the methylprednisolone IV dosage, we don't have clear-cut data. Nobody has really done a trial looking at 1 gram versus 500 mg. So when there is an acute rejection, severe rejection, we want to treat the rejection. So wherein we have to give high dose steroids. So different institutes follow different protocols. And we really don't have data to say that one is better than the other. It is an institution protocol, and it also depends on the given case.
Another question from the audience: how can we prevent, or is there any solution for chronic antibody-mediated rejection?
Correct. So it's a very important question. In fact, this is the question that is, that a lot of nephrologists are working on worldwide. So treatment of chronic antibody-mediated rejection is something which is being discussed. People are trying different things. People are trying to develop new molecules to treat chronic ABMR. There are certain treatment options which are like, which directly target the antibody producing cells like bortezomib, rituximab. There are certain complement pathway blockers also which are being tried in treatment of chronic ABMR. But again, the outcomes with a lot of these drugs is not that promising, unfortunately, because once these antibodies are well formed, well established, these antibodies, they remain in the body. So to take those antibodies completely out becomes really difficult. So, but there are studies being done targeting at these antibody producing cells to reduce the production of antibodies and to treat the ABMR. But at present, what usually we do is we increase the overall immunosuppression so that the antibody production is reduced. We try to give, in given cases, certain medicines like bortezomib to reduce antibody formation. And in acute ABMR, acute presentation wherein there is a lot of ABMR and lot of rejection, we give treatment like plasmapheresis, wherein we remove the antibodies and we increase the immunosuppression so that immediately the antibodies are taken away, and we increase the immunosuppression so that the damage is controlled. But if the damage has been going on slowly over many years, smoldering damage, so such aggressive treatments like plasmapheresis usually doesn't work, and they can have side effects. So we try to increase overall immunosuppression. We try medicines like bortezomib to reduce the antibody formation. And newer drugs are being developed, and I'm sure in a couple of years we should be able to use some of these novel treatments, new treatments for treatment of ABMR.
Okay, ma'am. Another question from an audience: how many years a kidney transplant recipient woman can get mom if she is healthy?
Okay, pregnancy, right?
Yeah.
So pregnancy after transplant, it should be a well-planned pregnancy, and it should be discussed well in advance with your nephrologist, and the women and the husband and the family should understand what are the risks involved. So pregnancy after transplant, yes, is possible, but it involves risk. Risk is involved in a pregnancy. Usually we say that at least a year, preferably 2 years post-transplant with stable graft function, should not have any rejections in the past year. Creatinine should be less than 1.5, no proteinuria, no significant proteinuria, well-controlled blood pressure, and on a stable dose of immunosuppressive medications is the ideal time to plan pregnancy. And when a pregnancy is planned, as I mentioned, the immunosuppression has to be modified, MMF has to be stopped, and you'll have to be started on azathioprine. And a close monitoring of TAC levels will be required. And blood pressure monitoring should be done very closely. You should understand what are the possible risks involved, like blood pressure going up, protein can come, proteinuria can happen, creatinine can go up. These are things which should be aware and should be closely monitored for.
Okay, ma'am. Thank you. Ma'am, one question from our audience, Muhammad Imrul Hassan Joshi. And his wife is his donor. And will the donor can take baby, her wife?
Yes. So Yes, donor can become pregnant in a normal way and have a normal pregnancy. Only thing is, again, close monitoring is required compared to a completely normal healthy lady from the general population. A kidney donor has a slight higher risk of developing blood pressure during pregnancy and what we known as preeclampsia. Okay, that there is a small higher risk compared to somebody from a general population. So those things has to be monitored, but otherwise, yes, she can, you know, become pregnant and have children. But again, it should be a planned thing, and you should have her kidney functions tested before, and it should be a planned, pregnancy.
লেট মি ট্রান্সলেট টু বাংলা। জোশী ভাই, মানে আপনার প্রশ্ন ছিল যে আপনার বউ বাচ্চা নিতে পারবে কিনা। হ্যাঁ, আপনার বউ বাচ্চা নিতে পারবে, তবে তাকে ক্লোজ মনিটরিং করতে হবে। আপনার বউয়ের হাই ব্লাড প্রেশার আছে কিনা, ক্রিয়েটিনিন ব্যালেন্স আছে কিনা, প্রোটিন ইউরিয়া আছে কিনা, এসব যদি সব ঠিক থাকে তবে রেগুলার ডক্টরের মনিটরের আন্ডারে থেকে আপনার বউ মানে বাচ্চা নিতে পারবে বা প্রেগনেন্ট হতে পারবে।
He has any children? No, he has children.
I don't have any idea. I have to ask him. Ma'am, another question from Javid Hassan Taufik. I had a breakthrough of varicella booster. My doctor reduced my AML dose. Then I am having spot urine PCR high like 0.37 to 0.57 from last 2 times. What should I do? My doctor didn't tell anything cautious about this.
No, sorry, I didn't get varicella. Varicella he had.
Mostly it's booster. Is a
vaccination.
Yes, I'm COVID vaccination.
Varicella booster, no varicella vaccine.
Most probably this is the
okay.
Booster dose
the
of
patient has taken the patient has taken the varicella booster.
Yes, ma'am.
Okay. So varicella booster, typically should not cause unless you got some fever after the booster. Sometimes fever post vaccination can cause some proteinuria. That should settle in due time. I don't really see a relation with the vaccination. But if proteinuria is there around 300 milligram, like he's saying, it needs to be closely watched, monitored. He can be started on certain antiproteinuric medicines. And if it is crossing 500 milligram, it is nearing a gram, then it needs further evaluation, may need a biopsy. But otherwise, it needs monitoring, and vaccination usually should not be associated. Yes.
Okay, ma'am. Another question from Shakil Ahmed. In case of primitive transplant, what are the consideration?
Preemptive transplant, right?
Yes, ma'am.
Preemptive. That means before you go on to a dialysis dependent stage, you want to get transplanted. Yes. So when we talk about in general transplant outcomes, somebody who is on dialysis for a long term versus somebody who gets transplanted very early on, the outcomes are better in the case where transplant is done early. So that way, preemptive transplant has its advantages. Having said that, we have to look at the donor, we have to look at the recipient, and we get time to plan things in advance. So if the patient has an elevated creatinine, we do few sessions of dialysis prior to transplant. That is the most common scenario. Sometimes in children, very young children, we do transplant in earlier stages before dialysis requiring stage, because their growth and development is affected by the chronic kidney disease. So we do a transplant much earlier in them. But in adults, usually when the CKD or chronic kidney disease progress to stage 5, the creatinine is beyond a certain range wherein we see that dialysis may be required in a couple of weeks or so. That is when we plan the transplant.
I have a mistake. The question was he has varicella virus. The doctor stopped mycophenolate and then PCR increased.
Okay. He has the varicella infection. Is the infection
Yes, madam.
resolved now? As the lesions resolved?
Reserve now and PCR got raised 2.57.
2.5.
No, 0.57.
0.5. Okay. So with a recent infection, PCR can get raised. Any recent infections can cause proteinuria. Varicella infection, if you have had, it can cause proteinuria. So it is a right thing that your doctor has done. Any of us would stop the MMF with a varicella infection. We have seen patients going into very severe varicella pneumonia and all with varicella. So it's good you have recovered from the infection. Some proteinuria after infection can happen. It should settle in due course of time. And I'm sure your nephrologist will decide on slowly restarting your MMF. And he will be keeping you under close monitoring. The proteinuria also he will be monitoring. Okay, so don't worry, because any infection can cause proteinuria. It should settle in due course of time.
Another question from Ahad Hussain. 27th May 2021, kidney transplant without dialysis. Currently, my medicine tacrolimus dose is 0.35, 3.5, and 3.5. Creatinine is 1.4. Reasons for high tacrolysis.
Tacrolimus was how much? Sorry, I missed it.
3.5 BD.
Okay. 3.5 BD. So tacrolimus, the metabolism, how the body uses tacrolimus is different for everybody. So some people, the body has an enzyme which will break down and use more tacrolimus. So those patients will need high dose. In fact, we have seen 10 milligram, 12 milligram of tacrolimus requiring. So some people, the body does not break down the tacrolimus so fast. It is genetic. It depends on your genes. And in fact, now we can even test for that specific gene prior to transplant. There are centers, there are situations wherein we do that, and we can tell you whether you're a fast metabolizer, slow metabolizer, or an intermediate metabolizer. Depending on that, we can decide on your tag dose also. So it purely depends on your body's metabolic nature of tacrolimus, that how much dose is required for you. So that is why we see the level, tacrolimus level, and decide on the dose. It is different for different individuals.
Okay, ma'am. Now, question from Nur Muhammad. Good evening. And my first question is: a Muslim transplant person can't fast as he has medicine plus water has to be taken on time. What is the problem? Is there is only 1 or 1.5 hour gap between fasting time?
Yeah, so fasting during Ramzan, that is I know it's a very thing that for transplant patients, it is it's not an easy question to answer. Yeah. There are 2-3 issues. One is with respect to water intake. So when in between the two morning and the evening time, when throughout water intake is not there, of course the medicine timings you can adjust according to the timings of fast, starting the fast and breaking the fast. And water intake, you will have to time it. You cannot take all the water together. So you'll have to take it before the time in 2 to 3 sessions. But close monitoring is required again. Because the tacrolimus levels also can get affected with your diet. You won't be taking anything in between, and you will, when you eat at once, so the absorption of the drug, the tacrolimus level can get altered. But now we have some studies from some of the Middle East countries and there are guidelines on how to fast, or what are the things to be monitored in a transplant patient during fasting. But again, there are very strict we are very cautious as nephrologists, because as a transplant patient, we are always worried about your kidneys. So we as nephrologists, personally, I would be really skeptical. But yes, if somebody is on a very stable dose, had no issues, is doing very well, Probably we can, adjust the dose, and I'm not very sure. But personally, I'll be little skeptical with respect to the kidneys. But yeah.
Okay, ma'am. In my opinion, we're talking about long-term effect of transplant. So it might happen
Yes.
after a Ramadan, we don't have any effect, but in the long run, it could happen. It could something may happen. But another thinking was most probably it was a cross-sectional study for the Ramadan or non-Ramadan. But
Yes. Yes.
is there any pilot study that after 20 or 30 or what was the reason?
Right. So I'm not aware of any such long-term study on somebody who has done fasting, regular fasting versus somebody who's not done fasting. So I'll have to really look into that. I'm sorry, I'm not aware about it.
Yes, ma'am. I'm thinking without a pilot study, how can we suggest a patient to get Ramadan fasting?
Right.
Most
Right.
probably
So
there
that
isn't any
is
pilot study.
correct. That is exactly my concern also. So as a nephrologist, we know what all a patient goes through to get a transplant done. And, to have a well-functioning transplanted kidney, it is not a simple thing. To any kind of risk, if it is my patient, I personally, as a nephrologist, I will have my reservations. So that is a personal opinion about it, because as you rightly pointed out, we don't have really to say how these the drug levels are being altered with fasting, and how the kidney functions are altered, and we don't really have those data, so it will be difficult to really tell. But again, this is a very personal choice also, right? So there those who believe in it, and for somebody it's very very important to fast, and so then it becomes difficult. So I think it's between the nephrologist and you, that you should discuss this and discuss in detail and understand, and then you should decide. So that's all I can tell. Even I have patients, chronic kidney disease patients, stable on, let's say, creatinine of 1.8, 2-ish, but stable for past long, many, many years, want to fast. But then again, I believe in discussing. Of course, it's your belief. I forget the name. You can give food, and to the poor, and you can do some donation instead of fasting. There is an equivalent thing which you can do right during the Ramzan. So it's all your belief, and it's your personal thing. So really, you should discuss with your nephrologist,
Okay.
and you should discuss.
And his second question is how long before and after taking tacrolimus should you eat? He's, he, he wants to know when she will eat tacrolimus and mycophenolate.
Right. So
Empty stomach
tacrolimus.
or okay.
Correct. So what is very important is that you follow the same thing throughout. So if, for example, if you're, we tell that you take tacrolimus on empty stomach, that is at least 2 hours before food. If you have been taking it morning and night, uh, 2 hours after food, or 1 hour before food. If that is what you are being following, please follow that regularly. But there are patients who don't tolerate; they get gastritis or taking tacrolimus on empty stomach. For such patients, sometimes we even tell that you take after food, but that should be followed continuously, because ultimately we are looking at the level. We are looking at tacrolimus level, and we are deciding on the dose. So
Okay.
if you're following that, you're taking it after food, let's say you're taking it about half an hour or 1 hour after food regularly, then please follow the same thing for both the dosage, and you follow it every time. You should take it the same way. So that becomes more important. Otherwise, that levels will fluctuate. You would be
That means
doing your TAC
consistency
level.
is most important.
Yes, consistency is most important, because TAC level we are checking at some point, right? So that will show some value. But let us say next day you are eating that medicine on empty stomach, and next day you're eating a full meal and taking the tablet, then the levels fluctuate. So the fluctuating level is not good. The level should be maintained consistently. So the food and the drug, the relationship should be constant. That is more important.
And here's the fourth question. And is it safe to change the tacrolimus or mycophenolate brand?
Yeah. So, especially tacrolimus. So, mycophenolate, I'll first handle the tacrolimus. Tacrolimus, because the drug, as I told, there is lot of between individual variation. The same dose, if you give to two people, the drug level in the blood is different. Again, we have even seen that with the same company, different batches. You know, the medicine also comes in batches. We have had that batch 1, batch 2 with some companies. We have seen some variation in TAC level. Somebody who was on stable dose, let's say 4 milligram daily, on a stable tacrolimus dose, there is a same brand, a new batch comes, and we see some variation in the TAC level. So tacrolimus as a drug is very sensitive to brands, to the way it is processed, and the way it is.
That means
What do you say?
different brands has different bioavailability.
Correct. So the brands, yes, tacrolimus brands, we have personally seen that the bioavailability, the TAC levels all vary. So that is why we don't encourage change of brand. But if there is a situation wherein it is inevitable, we advise to get TAC levels after changing the brand. So let us say you have changed the brand after taking 4 or 5 days of the drug, a TAC level should be done so that we know that if it is varying, if it is very high or very low, we'll have to adjust the dose. So that becomes very important. Without checking level, frequent change of brand, definitely not advisable. You may not see anything immediately, but when we talk about long-term outcome, these are things which could have an effect. But really, nobody has studied that, single brand versus multiple brand, how is it going to affect? But in practice, we do see that TAC levels, and like you rightly told, the bioavailability with different brands, we have seen changes in that.
Any question? I am just taking 1 or 2 questions. A question from Mustari Marufa. He had a successful transplant since 1 year back. His creatinine is 0.98 and tacrolimus level is 0.7 and everything is okay. Can she take baby or not?
Right. So, as I told, it is better if we wait for 2 years and your kidney functions are normal. We have to check for the protein leak, your blood pressure, how many medicines you're on. And how old are you? Is some age mentioned?
No, ma'am. She didn't mention his age.
No problem. So, yes, see, pregnancy definitely can happen. Successful pregnancies happen after transplant, but it should be planned and preferably 2 years after transplant. And please discuss with your nephrologist, discuss with the family what changes in your body will happen, what you should expect, what are the possible problems which you could face. That is very important to understand. That is one thing I want to tell all the women here. No, I understand how much you want to become a mother after transplant, how much that is wanted by a female. I can understand that, but having said that, you should also understand what changes it will cause in your body. Even a normal pregnancy in a woman causes a lot of changes in the body. So after transplant, the transplant kidney does go through a lot of changes with the pregnancy. So that is something which you have to understand before you plan a pregnancy. Before you decide that, yes, I want to become pregnant and have a child, please have this discussion with your nephrologist. Along with your husband, you should have this discussion. Especially when somebody is planning a second pregnancy, third pregnancy, these are very, very important, because transplanted kidney there is a stress that is put on the kidney with pregnancy. Even normal kidneys undergo stress, because there are normally two kidneys and the kidneys can withstand the stress. Normal pregnancies are uneventful, but lot of diseases, kidney diseases, become apparent. They are unmasked during normal pregnancies. There are normal ladies who develop protein leak during pregnancy. I'm not talking about transplant patients, and I'm not talking about CKD. I'm talking about normal women developing protein leak during pregnancy. It's becoming very common. High blood pressure, protein leak during pregnancy. So definitely those kidneys are not completely healthy. So when we talk about a transplant kidney and pregnancy, it is not a simple, straightforward thing. It should be a very informed, thought decision, and you have to discuss with your nephrologist. You should know what you are going to, going to go through, and take an informed decision. That is very important. And
Ma'am, it is
yes,
uh,
yes.
ma'am, it is common in Bangladesh to get kidney disease after pregnancy.
Oh,
Not
is
for the
it?
kidney patient, it's for the common people.
Yes, yes. So it is very unfortunate. So that is why all the more, you see, as I told, pregnancy is a like a litmus test for the kidneys. Pregnancy, the kidneys have to function many times more than what it normally does, which is happening in all women who becomes pregnant. This is something which I feel that women do not understand. Even sometimes the husbands do not understand. They should understand and then make a decision. Yes, I want a child, and I want to go through this. It should be an informed decision, and you should plan it. And another very important thing is fertility returns to normal immediately after transplant. You should have plans of contraception much before transplant, especially in women. We see a lot of unwanted pregnancies or unplanned pregnancies after transplant. Again, it puts a lot of pressure on the kidney. So these are issues which should be discussed with your nephrologist when you are planning transplant. When you are on dialysis, planning transplant, you should have all these discussions. And also, your husband should be in picture, and these things should be discussed much in ahead. Okay, yes, your health returns to normal. You become like a normal person after transplant. Your reproductive function, fertility, everything becomes normal, which is a great thing. But pregnancy is a huge change. Having a child is a very big responsibility, right? It's not a small thing. So all these things should be thought about. Many times women do not think. They think that, yes, being a woman, I should have a child. I should become pregnant. Yes, I understand. I have a daughter. I understand what motherhood is. But it should be an informed decision. You should know what it is before you plan it.
Ma'am, another question from 3 or 4 of us. They got infertile. They think they got infertile after transplant. And is it reversible? Their semen count is very low.
Oh, okay.
And so another question is when they are taking some supplement, the omega-3 or different type of supplement, these are safe or not?
Okay. So again, usually the medicines which we give do not cause low sperm count, and male fertility is, in fact, male fertility comes back to normal after transplant. Unlike when you're on dialysis, the fertility is really low. Post-transplant, the fertility and the sexual function, everything comes back to normal. That is what is commonly seen. Of course, I mean, if the test has shown that the semen count is low, there are, in general, health supplements do not harm. Omega-3 fatty acids or multivitamins do not harm. But the problem is with these alternative supplements, homeopathic, the health drinks, and not just homeopathic. I mean, in general, alternative medicines, we don't know the content. I'm not saying all are bad or anything like that. But some of these preparations, we don't know the content of it and how it interacts with medicine. So those in general health supplements are little, it becomes a tricky issue. But having said that, you can consult a urologist or a fertility specialist. Now we have options to treat male infertility, and specific these issues can be addressed. And I'm sure we should be able to offer treatment for that as well. Fertility shouldn't be affected after transplant in general. So if that is the case, we should be able to look at what is the reason, if there is anything else, if there is some thyroid issue or some other issue which is coexistent, which could affect that. And if not, if there is persistent low sperm count, now we have options of in vitro fertilizations and IVF, and or there are various other options also. So you should meet a urologist or a fertility specialist, andrologist, who will be able to help you out with this particular issue.
Ma'am, one question from a different individual. He got hydrocephaly after transplant, and it's huge. And will it harm his fertility?
Okay. Yeah, hydrocele is one issue which sometimes we see after transplant, but it must be on the side of the transplant kidney. I understand it should be usually unilateral. Usually, it does not affect fertility. It doesn't even affect your sexual function. But if it is huge, there is a chance of it getting infected. So if it's huge, it is better that he consults a urologist to see if that needs to be tackled. But per se, it shouldn't affect the fertility, as far as I'm aware. But if it is significant, it can cause issues, and he can meet a urologist, and the urologist should be able to help you with that.
Ma'am, we have to finish, and this is our last question from Jahid Bhai. And he had transplant 3 years back. After 3 months, he got T cell mediated rejection, and he has 30% damage of his kidney function. And his creatinine is almost stable, but hemoglobin got decreased. And now it is 9. He is losing his weight and muscle. How can he reverse his muscle and increase his hemoglobin level? And creatinine is almost stable. Is there any possibility got rise of creatinine? Oh, ma'am, he
Okay,
get ATG. He get ATG on that time.
when was this the transplant, and when was this rejection?
Ma'am, after 3 months, 3 months, he got T cell mediated rejection, and he got ATG, and then creatinine remain stable on 2.3 or 2.8. And recent
Now
problem,
the
he is losing
creatinine.
his
Now, how much is the creatinine? It's around 2.3.
approximately 2.8. Sometimes it raised to 2.8 or 2.9.
Oh. And when was the transplant done? How many years ago?
Ma'am, 3 years back.
Okay. So now,
Hemoglobin is 9 now. Transplant done in 2021.
okay. So if the creatinine is around 2.5 like that, and low hemoglobin, one thing is we'll have to check if his iron stores are adequate. Iron deficiency sometimes can cause. If the iron deficiency is not there and still hemoglobin is very low, sometimes we may have to start a small dose of erythropoietin, because his kidney function is not, completely normal. Creatinine is more than 2. That means the kidneys are not functioning as much as expected. So like how anemia develops in CKD patients, in a similar way, anemia or low hemoglobin can happen with elevated creatinine in a transplant kidney also. So such situations, we may have to start erythropoietin. First, of course, we look at the iron stores and see if iron deficiency is there. We try to correct that first.
Ma'am, his iron profile is almost good.
Okay. So then I would suggest that he should consult with his primary nephrologist, and I'm sure that if it is persistent anemia, usually we try to give a trial of erythropoietin if there is no other obvious cause. He should not be
Okay, ma'am.
losing blood from anywhere, but the loss of
He is
appetite.
recently losing his weight and muscle.
Correct. So that again, we have to see why he's losing. If we have to look at his appetite is good, he's not having any loose stools or any GI intolerance. So these are things which we'll have to look at. Of course, ATG was given long ago, 3 years ago, right? So that effect shouldn't be there now.
Mostly, as far as I know, he has bloating and
Okay.
digestibility issue.
Okay. So that again we'll have to evaluate in the post-transplant setting. If somebody is losing weight, lot of bloating, not tolerating. Sometimes some infections of the intestine or of the esophagus can be there. There can be CMV infection. Sometimes some fungal infections can be there, which can cause all these symptoms. So I think he should meet his nephrologist or transplant nephrologist, and they should be able to evaluate. If he is losing weight, not able to eat, it is definitely not normal. And creatinine of 2 should not cause those symptoms. Creatinine of 2.5 should not cause those symptoms. So there must be something else which we'll have to evaluate.
Okay, ma'am. Now we have to end. Ma'am, we have the last one question, Rayhana Begum. Which is better, DTP renal angiogram or USG of transplant kidney?
So immediately after transplant, we usually do a nuclear scan. The DTPA scan is done to see the perfusion of the kidney. Follow-up scans, we usually don't do DTPA routinely. I'm not sure if there are centers which do DTPA routinely on the follow-up. Follow-up, usually we do a ultrasound and a Doppler of the transplant kidney to look for the function of the transplant kidney. That is done on routine follow-up. Usually, the first year we do little frequently, probably monthly or 3 monthly, like that. Couple of scans are done. Then subsequently, probably once a year, like that, we can do a Doppler and an ultrasound to see the kidney. Repeated
Okay, ma'am.
DTP scans are usually not done.
Ma'am, one thing, some injection is used during DTP renal angiogram. Is it safe?
It is safe. It is renal safe. Okay.
Okay, ma'am. Ma'am, আমরা বোধহয় আর most probably you can understand বাংলা.
Yes, I understand, Mangla.
ম্যাম, অনেক ধন্যবাদ আমাদের এখানে আসার জন্য। মানে আশা করি আপনাকে এর পরেও পাবো। ধন্যবাদ, ভালো থাকবেন। আর ম্যাম, আমাদের এখানে অনেক পেশেন্ট এখন যে কোনো দরকারে অনেক প্রয়োজনে হয়তো আপনাকে অথবা এরপরেও ইনভাইট করতে পারে। আশা করি আমাদের সাথেই থাকবেন।
Sure, my pleasure. Take care, all of you. It was very nice interacting with you. And thank you, Rafi, for having me. And very happy to be part of this team wherein you said about 1,000 members you have.
Yes, more than
Right?
1,000. It's about 1.7K.
Oh my God. It's a great initiative. So creating awareness about kidney disease is the most important thing. And in fact, not just dialysis and transplant, the early stages of kidney disease also, people should become more and more aware. Like you said, pregnancy related kidney disease is there, common. And even chronic kidney disease, earlier stages, people should get treatment so that they don't land up in dialysis soon. Now we have treatment to slow down the progression so that people don't come on dialysis. We can postpone dialysis. And if somebody is on dialysis, how we can plan a transplant early. So you're doing a great job, and please continue doing it and continue helping patients.
Thank you, ma'am. সবাইকে ধন্যবাদ, ভালো থাকবেন। আসসালামু আলাইকুম। Thank you.
Walaikum assalam.